Okay. All right, let's get started, everyone. Welcome to conference, and thanks for joining. We have a few residents here in person at the university who will be participating in person. For those of you who joined via Zoom, please feel free to enter your comments and questions into the chat. We're going to have a diagnostic reasoning conference today. It's a little bit of a different style than what we've done, so we'll see how this works. So today, what I thought we would try is a case where we have two very similar patients, and we'll go through, and when you ask a question, I'll give you the information for both patients, and then we'll see sort of what makes them different and why the diagnosis is what we arrive to it. So the information that I'm giving you to start with is that both of these patients are 67-year-old men who are presenting with abdominal pain. And so today we will spend a little bit more time where y'all ask me questions about their presentation, their past medical history, etc. So let's focus on the top box here, the subjective box, and get started.
Tell me more about your abdominal pain.
Okay. So tell me more about the abdominal pain. Okay. So the patient says, started yesterday for both of them, and it's lower in my lower belly, and that's what the patient tells you.
Just like the entire lower belly?
No, it's more on the left side.
Is it constant or intermittent?
Great. So the questions that we're getting here at the university are more sort of about the OPQRST, which I think are pretty important when it comes to abdominal pain, to try and figure out exactly what's going on. So they asked about whether it was constant or intermittent. Patient 1 says that his pain is constant, but intermittently feels worse. And patient 2 says that his feels crampy. It like comes and goes.
Like nausea, vomiting, diarrhea.
Yeah, thanks for specifying that. So a little bit of the ROS. Okay. So some abdominal pain related ROS. Any nausea, vomiting. What else did you ask?
Diarrhea.
Diarrhea. Okay.
Blood and stool.
Great. So no nausea or vomiting. Patient 1 says, yeah, I sometimes see blood in my stool, but not for the last 5 days.
Do either of these patients remember a precise moment when their abdominal pain started?
They don't, no. They're like, it kind of just slowly got worse and worse, and so now I'm here today.
Great.
And for the second patient, no nausea and vomiting, and he did have a bloody bowel movement today.
For the first patient, he said no blood in his stool for the past 5 days, but has he had a stool for the past 5 days?
Yeah, he has had, yeah, he's had stools.
Is the blood in the or has that been happening throughout his life? Or?
Well, he said it's been happening since he was about 55-ish, and it doesn't happen very often. He just thought it was hemorrhoids, and so he hasn't really mentioned it to anyone else before. Has he had a colonoscopy? Yes, he has had a colonoscopy in the past, and he does not remember what it showed, but the doctor said he could get it in 10 years.
Does he have any family history of cancer, autoimmune disease?
Okay, question about family history of cancer, autoimmune disease. Dr. Kusari, tell me why you're asking those.
Just to see if like we're looking at the entire up on your differential and then an IBD.
Okay. So let me fill some information in here, since I told you I'd tell you about both patients. So for the second patient, he has never had a colonoscopy before. And no family history of GI cancers. or rheumatologic diseases for either.
Fevers, chills for either of these guys?
Yeah, great. No fevers, chills for either.
Any alleviating or exacerbating maneuvers or things?
So the first patient says they haven't really noticed anything that makes it better or worse. The second patient says, well, I just stopped eating, and that has at least made the pain stop getting worse.
Does the first one have CAD or like known heart disease?
Yeah, great. So let me answer those questions. The first patient has osteoarthritis in his knee. He has hypertension, and he had a stress test which was negative 2 years ago. The second patient has hypertension, diabetes. He had an MI 7 years ago. And I forgot to mention the first patient also is obese. Okay, maybe let's pause here just for a second before we let you ask more questions. And let's go through these people's differentials. And so what do you guys think falls in the differential for both of these patients?
Make it bigger.
I make it bigger, yeah.
Oh, should have asked about that one. Colon cancer.
Okay,
I don't think that's the most likely. I'm just trying to.
that's fine. No, I think we're early enough in the disease course, right, that we're gonna have a pretty broad differential right now. So Sophie, do you want colon cancer in one or both?
More so on the second one, I would say, than the first one, but yeah,
And tell me why more so in the second one.
just because he's never had a colonoscopy,
Okay.
and it's normally that would. And then, yeah.
Tell me if you think the presenting symptoms or the way they're presenting makes it more or less likely that they have colon cancer.
I would say less likely.
Less likely, right? Because usually colon cancer doesn't present like this unless it's like so big now that now they have an obstruction and that's why they're having all this pain, right? But generally colon cancer, either we pick it up on screening or the patient comes in really ill if it's large enough. But I think it's reasonable, especially for a patient too who's never had a colonoscopy, to put it in the differential.
The patient number 2, they stopped eating because when they ate it, what happened?
Yeah, he was just like, you know, when I ate, like my pain maybe got a little more crampy, so he's like, I just decided to stop eating.
Yeah, so chronic mesenteric ischemia is when the difference.
Okay.
Especially where he's had an MI.
Do you want me to put that in patient 1 as well?
Sure.
I feel like that one, diverticulitis.
For number 1.
Yeah. Yeah. Which one had bloody bowel movement? First one?
The first one has had blood in the past, the second one has blood now.
I still put IBD on both of those.
Okay. That's great. Ariana, what about them might make IBD not as likely?
Just that it's not like, you know, like multiple bloody bowel movements a day, having
Yeah, great, thanks for pointing that out. So, ulcerative colitis currently has a bimodal distribution, and so it would not be unlikely in this age range. It is closer to like the 50s and 60s as opposed to closer to 70s, but yeah, I think it's important to put them on both, especially with them having bloody bowel movements. So they're not as frequent as we normally expect in patients with IBD presentations.
Doesn't seem like too much of an infectious etiology, just because they denied any other systemic symptoms. I think something that typically you ask is like, if they're not having diarrhea, but like, is the diarrhea like waking up at night? Is that, that could point towards more like an infectious etiology?
Yeah, we can put that here. So, what would point toward infection would be diarrhea, fevers, chills, and then if they had diarrhea, you'd ask more questions about diarrhea, like, are you waking up at night with it? How frequent? What does it look like, et cetera, okay? And if they were having diarrhea, what things would you add to the differential for these patients? We won't add them here, but just as a thought exercise.
Like an EHEC or Shigella, it's gonna be like more bloody diarrhea type presentation.
Yeah, so I think all the diarrheal bugs that can cause abdominal cramping and diarrhea, right? Salmonella, Shigella, Campylobacter, E. coli, and then C. diff, we mustn't forget. So C. diff is in there too, right? Okay. All right. So let's go back. I can answer more questions up here if y'all want. Otherwise, we can get into the exam.
Just to keep my differential really broad, particularly for the left guy, any hematuria, just to rule out if there could be like a kidney stone.
Yeah, great. So,
Extraintestinal as well.
yeah, thinking extraintestinal, the belly is a big area with different organs, and so no hematuria. I'll just put it for either.
Any alcohol use, smoking history, substance use.
Great. So the patient on the left has a 40-pack year smoking history and continues to smoke. This patient on the right smoked 10-pack years and quit 30 years ago. And neither drinks excessive alcohol. Why would alcohol matter here?
Like if it's ascites pain and
Sure.
maybe they're having orthopedics that have a rectal varices.
Great, yeah, if it's ascites and they may have varices, if we're considering that they have liver disease that they haven't picked up on or hasn't been diagnosed yet, okay?
Pain due to distension from their ascites.
Pain due to distension from their ascites. Thank you for making that clear.
Apologies to the Southern aspect, any of them had, abdominal surgery?
No, neither have had any abdominal surgeries before. But great question.
Small bowel obstruction.
Small bowel obstruction, yep, from adhesions is classic there.
Like how severe is the pain?
How severe is the pain? For patient one, it's tolerable. It's there, but it has been getting sort of worse in intensity as the day's gone on. For the person on the right, when it's sort of at the height of the cramp, it's pretty bad, and then it sort of abates, but it's, yeah, it's sort of bad.
Then is this in the ED that we're seeing them, or where are we seeing them?
Yeah, we're seeing them both in the ED.
Okay.
Yep. And then Dr. Happy comments, for smokers with normal BMs would suggest broad and differential to extra, malignancy, otherwise in vascular AAA. Great. Okay.
Well, can you clarify whether the blood and stool is like somatotypia versus like melena?
Yeah, I can clarify in a second. All right, so for patient one, when he has blood in his stools, it sort of just follows his BM, and there's a little bit of red blood, not melena. And then the right side patient is having sort of had a bloody diarrhea-like bowel movement today. But only one. And we can always keep going back to the differential and move things up or down if you guys want, or add things. If stuff pops up in your head.
We'll get some.
Yeah, we can get some labs. Do you want something else before the lab? An exam. An exam might be helpful, right? With abdominal pain, I think, you know, for most people, it's like, yeah, it hurts, but I think it's helpful to do one anyway. So.
Oh.
Not always, huh? Okay.
That's one of those chronic abdominal pain paralytic.
Okay, let me put the exam here, and then. Okay, let's just do sort of the vitals and, the abdominal exam. The rest we'll assume is, fairly normal / chronic. So for patient one, afebrile, heart rate's 80, blood pressure is 130/88, batting well, 98%. Patient right. Same item. Okay, for the abdominal exam, I want you to tell me how you're going to examine these patients and what you're looking for.
General inspection first, is it distended or not?
Mm-hmm.
Are there obvious, well, sounds like no history of, prior surgery, but we'll look at scars.
Yeah, scars, distension. These patients have neither. They don't look distended.
We're classically taught to listen before, so I always forget to do that.
Nice. Classically asked to listen before palpating.
Definitely not.
Normal sounds here. And the patient maybe has somewhat hypoactive. But they're not absent. Okay, what next? Palpation, yeah. So for the patient on the left, there is tenderness to palpation, but there's also mild rebound. And then for the patient on the right, there's tenderness to palpation. And for both of these patients, the tenderness is localized to the left lower quadrant. But this patient otherwise has no rebound. Both are guarding a little because they're in pain. But it's voluntary. Okay, does that help with the differential at all? Moving things up or down?
Not really.
No.
Well, I think if you're capturing true rebound tenderness, and you're rebound tenderness, that alludes to something causing peritonitis.
Okay.
And so things that are completely and utterly unrelated to peritonitis would go lower, and things that are would go higher.
Okay. Do you want to move something higher?
If diverticulitis is on there, I'd move that up a little bit.
Should we move it up top?
Yeah, sure, why not?
Okay, because diverticulitis, okay, so it's based on his teaching us that if there's true rebound, he's concerned for peritonitis, which is usually sort of inflammation in the bowel wall, which is now eroding into peritoneum, your different fascias, and so we moved diverticulitis up.
I feel like a lot of these things could have like a benign abdominal exam, so that's why it's hard to differentiate some of these things, higher or lower, but I guess what you're saying based off of your exam.
based off the exam, yeah.
Cause there's like,
Second guy without finding.
there's like rebound, like you guys thought, oh, it's a little worse, and then they like, there's rebound, they almost jump off the table.
Yeah.
If it's, they almost jump off the table, that means it's worried about peritonitis.
Peritonitis, yeah. So, you know, this is why we're doing this exercise, because I think abdominal pain is similar in like most presentations, and so it's gonna be these little subtle things that you have to pick up when you ask the questions to your patients and when you look at their past medical history. And then obviously imaging is immensely helpful, and we'll get there, but it's helpful to build a differential and like move things up or down as you move forward in the patient's case. So for labs, patient left has a normal BMP. Their white count is 13. Their hemoglobin is 13. And their platelets are normal. And you guys tell me if you want anything else. LFTs are normal.
It is CRP on both.
Yeah, CRP on the left is, I don't know what's the lower limit. It's like 35 and mildly elevated.
It is recognizing the fact that there is evidence of vote.
And for right, normal BMP, my count is 9, and CRP here is normal.
The AP
Someone on their iPhone, you can just,
Remember to mute.
okay, I can't, oh. All right, team, where are we now?
Sorry, are both of those BMPs normal?
Yeah, BMPs are normal, sorry, I didn't write that here.
I like a lactate.
Okay. Jennifer, Jen wants lipase and a UA, that's great. Lipase sounds, obviously, we really only got it for pancreatitis, right? Lipase normal for both. And a UA is normal in both. Jen, can you tell us why you want a UA? I'll give you some time to type.
And what was the lactate?
Oh, lactate normal in both.
What's the MCT on that?
Oh, great question. Because both have a little bit lower hemoglobin for males. Yeah. You know, both are normocytic. Okay, Jen says, oh, just to rule out nephrolithiasis. Yeah, great. I think Natalie asked that earlier too, just to make sure she's keeping that in mind. And the UA is normal for both, no blood in there.
We may have glossed over this, but are either of these guys on any outpatient medications?
Yeah, so we did gloss over medications before, and are either on medications. So the first patient pretty routinely takes ibuprofen for his OA. He otherwise is on amlodipine, and that's it. And the second patient, because of his MI, is on aspirin, he's on Atorva, he's on Metope, he's on HCTZ, which was recently increased, and then he's on metformin. Do those medications help you, tell you anything?
I was just thinking in that second guy especially, that was kind of hypoactive bowel sounds. I wonder about gut motility, if he's on anything that can kind of slow down gut motility, but, or potentially in like diabetes, yeah, can slow gut motility.
Sure, yeah. So for the second guy, worrying about gut motility and if there are anything that can slow that down. Great. Well, what would you like to do now?
We didn't get a rectal in either of these people, did we?
Brady, we did not yet. We can.
I think if both are coming in saying that they're having blood, they deserve a rectal exam, although I know we don't often do them.
Great. If both are coming in saying that they're having blood in their stool, we should probably do a rectal exam. The last patient's rectal was negative. I don't know if you want an FOBT with it or how helpful you find them, but the right side patient, where did I put that? There is some blood on your glove. Jason, I wish I could make this bigger for you.
It's okay. Getting old. HIV, so Dr. Albert.
I want HIV status. Dr. Albert, can you help us understand what you're thinking there? Anal cancer. Oh, that's a great point. Yeah, both have had HIV tested multiple times with PCP routinely and have always been negative.
So the person where there's blood on the glove, I don't, could probably come up with some stuff to order, but he probably needs an EG, a scope.
A scope. Okay.
You know, like I would call GI to evaluate for a non-urgent, but probably inpatient scope, if they're in the hospital.
Okay, great. So Jason says for the right side person who has blood, now he's telling us he has bloody diarrhea, the only one time, and his hemodynamically stable, his hemoglobin stable from before, that we would call GI for a non-urgent colonoscopy, but probably on the inpatient settings that we said.
If they're admitted.
If they're admitted, okay. All right. So we'll consider that. What else? I'd like a CT abdomen pelvis with contrast. Well, on both, but definitely on the left.
Yeah, it's already been done probably.
Great. Okay, so we're having some jokes about how we definitely want a CT abdomen pelvis with contrast for both of these patients, and that pretty much 100% of the time the emergency department colleagues of ours will have done that for us, which is really helpful, because really what's happened now is that even with all the questions we've asked, all the labs and exams that we've done, we still have a few things sort of equally likely on our differentials. There are subtle hints to why something might be more or less likely in these patients, and we'll talk about that, but that's what we want for both. Okay. With contrast. Excellent. All right, so let's give that to you. Here it is for the first patient, and here it is for the second patient. Zoom in for you, Jason.
Sorry.
I can read it. The first patient has diverticula through the colon, fat stranding adjacent to a sigmoid diverticulum, no signs of pneumoperitoneum. And the right side patient has a normal CT. Okay. So for one of these patients, we have the diagnosis.
I'm so sorry, that was just a normal CT with like IV, like venous contrast. It wasn't time for like a CT angiogram.
It was not a CT angiogram, it's just a CT with, yeah, normal, whatever contrast they do.
Okay.
Okay, what do you guys think is the diagnosis for patient number 1? Diverticulitis, right? Very obvious. Focal fast stranding adjacent to a diverticulum with the presentation is a diagnosis of acute diverticulitis.
And I think the labs were really helpful for thinking that there was either something inflammatory or infectious going on. We kind of breezed over the CRP, but, versus the other guy who doesn't have any signs of inflammatory process going on.
Yeah, great. So Dr. Campbell mentions that the labs were really helpful for patient number 1 because his white count was slightly elevated, his CRP was slightly elevated, and so we're worried about sort of this acute inflammatory / infectious process, and diverticulitis certainly an inflammatory process, though can move into infectious if it's untreated, more severely infectious if it's untreated. Great, Meryl's diverticulitis as well. Okay, so we'll table patient number 1 for a second before we start treatment. What do we want to do for patient number 2? Meryl, colonoscopy. Meryl, please tell us why you want a colonoscopy.
I just think, again, because you didn't get intraluminal contrast, that the normal CT is just not a good test for colon cancer.
For colon cancer. Okay, so we're still thinking colon cancer in that patient. Okay, so Jason, GI agreed with you and did want an inpatient colonoscopy.
I'm blushing.
And here is what happened. So in this patient, it was required, given normal CT, and it demonstrated pale edematous bowel near the splenic flexure.
Sounds cancer.
What else? Okay, Jason thinks maybe sounds cancery.
That is not good.
Sounds like a watershed.
Watershed, so what's the diagnosis?
Colonoscopy ischemia.
Yeah, ischemic colitis or chronic ischemia. Good.
It's healthy otherwise, people can.
Yeah, you don't always have to have elevated lactates in ischemic colitis. Often it's a mild sort of terminating diagnosis. It has different phases and different severities, and it's only until a severe phase where you have enough ischemia that you have lactate.
Yeah, and in fact, Sneha, an elevated lactate is a late finding, and so like by the time if you're getting a lactate back that's 6, 7, 8, 9, we're already kind of behind the 8 ball a little bit.
Mm-hmm. Yeah. So we want to make that diagnosis early in its phase, right, and then start appropriate treatment. Okay, so we will not spend, Dr. Albert said, surprised that they didn't see bowel wall edema on CT. Yeah, thanks, Dr. Albert. So in reviewing ischemic colitis, CT with IV contrast is one of the first studies that we do in these patients, but in many cases, the CT scans are normal and the test of choice is a colonoscopy, and we'll talk a little bit about that here in a second too. So what do you guys want to treat our diverticulitis patient with? First, let me ask you this. Do you think this patient needs admission? No, Jason's shaking his head. So remember, diverticulitis presents with a spectrum. This patient would be categorized as having acute uncomplicated diverticulitis. On CT scan, there's no pneumoperitoneum, there are no signs of abscess, there aren't even really that many signs of perforation, and so this patient can be safely treated in the outpatient setting. And what antibiotics do you want to use? Augmentin, yeah, that's an option. Usually ciproflagyl, as I heard back there, is the treatment of choice. Both have excellent oral bioavailability, and so PO is fine. If this patient were having high fevers, they were hemodynamically unstable, they were having nausea and vomiting to the point that they couldn't tolerate PO intake, these are some signs why they might need inpatient admission, plus minus IV antibiotics. Okay. And then what do you want to do for our patient number 2? Admit the patient. Yeah, so ischemic colitis is a little bit trickier in terms of what we're going to do with the patient. Usually they do end up getting admitted. They need some IV fluids, some rehydration. Therapy is conservative. Since the CT was overall normal, and there aren't other signs of this patient having, again, perforation, local infection, we wouldn't choose antibiotics in them, but say their case were a little bit more severe, where they had a fever, or they had ongoing diarrhea, you're concerned that their bowel wall is going to cause translocation, and those patients also get antibiotic treatment. And then more severe cases have to undergo surgical intervention. But in this patient, we are just going to give him some IV fluids, supportive care, and bowel rest, which he's already started doing at home, right? That was making his pain a little bit better. And so you're going to rest the bowel until his pain gets much better, / goes away. Okay, what questions do you have on what we've just done? I have a couple more teaching things to go through.
Does piece number 2 need like an further workup for like source? Like, is it embolic versus not?
Yeah, great question. Does case number 2 need a further workup for source of why they have this ischemia? So Dr. Campbell is mentioning this is sort of an obstructive or occlusive type of ischemia. A lot of patients who are elderly also have a non-occlusive type of ischemia. And so with this patient's previous history of an MI, they have hypertension, diabetes, all of these do put them at risk of having micro-vascular changes, and so more likely to have non-occlusive ischemia. His hydrochlorothiazide was recently increased, and so diuretics can often precipitate some of this type of ischemia and get patients a bit dehydrated, and so making sure they're on appropriate low-dose medication so to not cause this again. But yes, you should work them up for other occlusive causes. And so, you know, are there signs of endocarditis, which this patient doesn't have? Do they have atrial fibrillation? It's something to think about with a previous MI. Yep, so you should be looking for occlusive causes. This patient, beyond just being on his aspirin for his heart disease, does not need anticoagulation, even with this ischemic colitis episode.
If he wasn't already on the aspirin, would you start it for this? Is that a part of that treatment, or like statin as well, or not?
You know, I will say I didn't look into that specifically, so I just don't know the answer. Yeah.
I don't know how many of these people don't have like
Right.
heart disease and
Yeah.
diabetes and
Yeah.
other indications.
A majority of patients with occlusive, but really also non-occlusive, have microvascular risk factors, which are our standard coronary artery disease, peripheral arterial disease, diabetes, hypertension, et cetera.
Yeah, we should look into that, but I think, I can't think of seeing this without people who were like already merited.
Putting a high enough
for other
ASCVD, yeah.
Okay.
And I mentioned his LFTs were normal, but actually a good amount of patients with ischemic colitis also have hypoalbuminemia. I don't know sort of what the cause there is or the pathophysiology of that, but that's considered a risk factor. Any other questions?
So it sounds like CTA is not not helpful for your colonoscopy, like you just did.
Correct. CTA is not helpful in this particular case. We will talk about when you should get a CTA. Okay, so let's go there. If you have any more questions, feel free to ask. All right, so first I wanted to go through something that I do routinely in my practice, which is to look at the American College of Radiology's appropriateness criteria for when I should be getting imaging for patients, and especially for abdominal imaging. This is a really helpful resource. You just go to Google, type in ACR appropriateness, and it'll bring you to the page that lets you put in different diagnoses to see what you should be ordering. So for patients with left lower quadrant pain where you suspect diverticulitis, like we did on our patient number 1, you all very appropriately ordered the right study, which is a CT abdomen pelvis with IV contrast. Say we had a patient that had acute non-localized abdominal pain, this left-sided pain, but you're like, it's not really diverticulitis, I don't know what to do. They also have a sheet for that. This patient didn't have fever, so we'll pass that. He also isn't post-operative, not neutropenic. And so we end up in this category where it's not otherwise specified, right? We're in the vague, generic area as we ended up with patient 2. Again, the correct study would be a CT abdomen pelvis with IV contrast. And so that's why when our emergency department does this test for our patients with abdominal pain, they are choosing the appropriate test because most of their patients down there have fever, don't have fever, whatever. Really the first choice is CT abdomen pelvis with IV contrast. Okay, so there was a question of when to think about CTA, right? So Jason, Dr. John earlier mentioned he was worried for patient number 2 about chronic mesenteric ischemia. What we more frequently hear about is acute mesenteric ischemia. And I should actually update that slide to make it more accurate. So let's talk about the difference between ischemic bowel and acute mesenteric ischemia. This is something that always confused me. For a long time, I thought this was the same thing, which it is not. So we should be thinking about that differently. They're on a spectrum, which is that all of these are related to blood vessels not supplying enough blood to different parts of the bowel, right? Ischemic colitis is just the large bowel that isn't getting enough blood. Acute mesenteric ischemia is the small bowel not getting enough blood. And in thinking about who gets these, so ischemic colitis is really a disease of patients who are advanced in age. So most cases happen when you're older than 60. They usually are not ill-appearing. They have mild abdominal pain, as this patient had. There is tenderness present over the area of ischemia. Bleeding and diarrhea are common during the acute case of it. And then treatment, like I was saying, depends on severity, but usually it's conservative and mostly just limited to IV fluids. The diagnostic study of choice to start with will be a CT abdomen pelvis, and if it doesn't clear-cut show you the diagnosis like Dr. Albert was mentioning with wall edema, then you're gonna next step go to colonoscopy. Okay? Acute mesenteric ischemia is a much more scarier entity, and that's why it's in red here. You can have it at any age, depending on your risk factors and the etiology of the ischemia. And so please think about it in patients of all ages if the clinical sign is appropriate. They're usually very ill-appearing with severe acute pain. This is an acute diagnosis. They have pain out of proportion to exam. And so their exam will be like, well, they don't really seem that bad, but they're dying of pain. And this is an early sign. You really don't want to let this disease get in the later phases because the mortality is quite high, so we got to catch it early. Bleeding is uncommon until much later in the course, but a lot of the bowel has died by then, and so again, we don't want to get to that stage. The treatment here is multifold. You're going to anticoagulate these patients. The number one, the etiology is the SMA thrombus or embolus, right? So you want to anticoagulate these patients. They do need antibiotics always, and typically surgical or IR interventions are very common, and that's why we need an angio study for patients in whom you suspect mesenteric ischemia. So your study has to have the word angio in it. So whether it's a CT angiogram or just straight angiography where they shoot contrast into your blood vessel to look at what's going on, and IR will be the ones who do that, right? Sometimes they also do staging angiography. So if vascular surgery will do pre-angiography before surgery to figure out where they're going to direct the intervention to look at where the blockage is. And so really acute mesenteric ischemia, anytime you get called for patient with abdominal pain that's ill-appearing, you should be thinking about, in the right context, right? These patients have hypercoagulable states, they have atrial fibrillation, endocarditis, reasons to have an embolus or a thrombus in their SMA, but something that we should pick up early because they need surgical intervention to save as much of the bowel as we can. Okay, so today we considered the subtle differences and how they change the differential. And so just remembering that the second patient had many more risk factors for having micro-vascular disease. He had an episode of bloody diarrhea, all of which are more common with ischemic colitis. The first patient, you did a great job in diagnosing diverticulitis. And then we talked a little bit about these two diagnoses. So for our self-directed learning today, I want you to think about which conditions you would expect to find pneumoperitoneum, and then would anybody like to tell me what's wrong with the patient above? Yeah, they have pneumoperitoneum, they have air under the diaphragm here. So when I read chest x-rays, I always look at under the diaphragm first to not miss air that may be hiding there. So great job. And then just a plug, Danny was one of the radiology chief residents, did a abdomen radiology conference recently, and so to look at how we read abdominal imaging, I think this is a really great conference. So I would highly encourage you to go and watch that after today's conference. And that's all I had. I wanted to wish a happy Lunar New Year to those celebrating, and I'm here for any other questions.